Hey everybody, this is Eric back with you with FlightBridgeED. This morning I wanted to talk to you about cardiac pharmacology. We just did a podcast on sepsis, and I thought it'd be fitting that we go into some different cardiac medications as it relates to our ICU patients. I've had a lot of people talk to me or ask me questions about pressors lately, which pressor to utilize in different situations. So I'll touch base on a few of those. We'll take about 10 or 15 minutes, make this podcast brief, and talk about action, indication, contraindications, and things like that. So why don't we start off first? We'll kind of recap how things work. Remember, we have beta 1, beta 2, we have alpha, alpha 2 stimulation as it relates to different medications and how our body utilizes, or I should say, how we administer medications and how they affect the body. So we got the heart. If we want to affect the heart, we want to affect conduction, rate, contractility, then what we're doing is we're giving a medication that's beta 1 as far as its action. If we give a medication that primarily affects the lungs, like albuterol or things like that, we're affecting the beta 2 receptors. That's going to give you bronchodilation. We're going to decrease secretions and things like that. And we're talking about medications that really don't affect the heart or the lungs, and we're trying to stimulate, vasoconstriction on a higher level. Then we're talking about medications that stimulate the alpha receptors, and we're going to have massive vasoconstriction. So we'll talk about those medications when we use those. And then we got to also remember we have medications that are better as far as inotropic versus chronotropic. So inotropic, remember, is medications that affect contractility more so than heart rate, whereas chronotropic is going to affect the heart rate more than contractility. So we'll talk about medications that we may use that will affect those primarily more than others. Obviously, you do have other aspects of beta 1, beta 2, alpha, and alpha 2 that stimulate things. So if you give a beta 2 medication, you can have skeletal muscle stimulation that's going to cause some increased contractility. So, if we talk about a medication like dobutamine is a primarily inotropic medication where it has excellent contractility effects. You'll have some initial vasodilation when you give medications like that. Other things that beta 1, alpha 1, you're going to have alpha stimulation for your liver that basically increases glucose. You're going to have kidney involvement with beta 1 medications where you're going to have renin secreted. We know that is the renin-angiotensin cycle that stimulates an increase in blood pressure. All right, so agonists versus antagonists. Remember, we have medications that potentiate things, and we have medications that block things. So agonist drugs bind with the receptors, and they mimic the true intrinsic action of those receptors. So example would be epinephrine or norepinephrine. So those are agonists. An antagonist drug would be something that binds with the receptors, blocks the intrinsic action of those receptors. Vecuronium would be a perfect medication that would give an example of that, and that would be because it's a competitive neuromuscular blocker. If you remember from my earlier podcast on RSI, we have competitive and non-competitive neuromuscular blocking agents. Competitive means that it's blocking that receptor site. It's not allowing acetylcholine to even go into that neuromuscular junction and activate firing of those impulses, where succinylcholine is a non-competitive neuromuscular blocker, and that medication actually fills all of those receptor sites. So an antagonist medication would be vecuronium. That would be a great example of that. We'll start off really quickly with beta blockers. Just identify. Remember, beta blockers can be identified with olol. They're always going to end in LOL. So examples would be esmolol, metoprolol, Vasopressor, things like that. Again, these are antagonists. They block beta receptors of the heart and lungs. Some of these beta blockers are going to be more beta 1 specific versus beta 2. You always want to remember, though, when you're giving a beta blocker to always look at the patient's past medical history, identify if they've got any asthma history, anything like that. You don't want to give them a beta blocker medication that is going to cause you to have problems if they did have an asthma attack or or something like that, because you're going to block those beta 2 receptors. We give these medications more so now for hypertensive crisis. Earlier on in the last maybe 5 or 6 years, we were giving low pressor a lot in MIs, but they've identified that that's probably not the best option. And really the only option that you're going to be given low pressor in that context would be if you have somebody that has a high blood pressure despite your pain management aspects in an MI situation. So you've given them fentanyl, you've given them morphine, you've given them nitro drip, all those things are still hypertensive after those. So kind of the philosophy now is treat the pain, be aggressive with your pain management, and manage that. Don't worry so much about giving a low pressor where it's going to drop the heart rate down. And so the thought is if you treat the pain aggressively and you're generous in that regard, just by doing that, you're going to drop the blood pressure and the heart rate, and you're going to take care of itself. When we talk about a few beta blockers, one of the big ones is esmolol. Esmolol is primarily a beta 1 beta blocker. It's got a very rapid onset and it's very short acting. It decreases blood pressure and heart rate, and dose is dependent to the situation. So we're going to give these medications in SVT. You can give these medications to control prolonged hypertension. Always want to make sure that you're using caution in asthma and bronchial spasm patients, or any patients that may have a continuous bradycardia, AV blocks, and we know those things. You're not going to give a beta blocker in those situations. So just remember that esmolol, some EMS agencies aren't going to know these medications. Some flight agencies still don't carry esmolol, but be familiar with them, understand what they do. All right, so the next kind of medication we're going to talk about, we're going to go right into vasopressors and inotropes. So that's the main purpose of this podcast. So remember, we have vasopressors and inotropes. They can be kind of used as far as multiple etiologies, and so a few to just right off the top: dopamine, epinephrine, dobutamine, norepi, neosynephrine, and vasopressin. And we're going to talk about the first 5 there. So the big thing about vasopressors is we're causing vasoconstriction, inotrope, or increased contractility. All these medications act directly on the central nervous system, so we got to be aware of that. They have a sympathetic response, and so which medication do we use, and where do we start? So let's first start by talking about inotropes. Inotropes would be dopamine and dobutamine. Dopamine is going to be more of a chronotropic effect, so it's going to have greater heart rate effects. You are going to have some increased contractility, and then dobutamine is going to be primarily inotrope in nature, and you are going to have a little bit of beta 2 and vasodilatation effects with that, and I'll explain that here in a second. So the action of a inotropic medication is to basically increases contractility, increases heart rate. Dopamine causes vasoconstriction if it's dose dependent. So we have a dose range of 2 to 20 mics per kilogram per minute. Dobutamine causes vasodilation. We'll talk about why that is and how we're going to combat that when we give that medication. Indications we're going to use it for acute left ventricular failure, cardiogenic shock, any patient with a cardiac output that's low or low perfusion states, or vasogenic shock. So if we start with dopamine is going to be utilized in different indications. I think if you read different articles, you're going to have multiple physicians that say dopamine is going to be used in for different indications. Dopamine is going to be the first medications we're going to talk about. This is given in 3 different levels, and you can see that we have the first phase is going to be dopaminergic. It's going to have primarily beta stimulation. We're going to have increased contractility, increased cardiac output, increased renal perfusion. So these are low doses, 2 to 5 mics per kilogram. I will say that dopamine in the pre-hospital setting, when we talk about EMS, starting doses are usually 5 mics per kilo. When we start increasing dopamine greater than 5 mics per kilogram, per minute. You're going to start seeing alpha effects as well. So you're going to have increased cardiac output, increased contractility. You're going to have blood pressure effects, and that's where you're going to start seeing the heart rate effects. And you lose that renal action. So you only get that renal perfusion in very low doses, 2 mics per kilogram per minute. And then we have the higher range where we're getting greater than 10 mics per kilogram per minute. These are potent veno and atrial constricting effects at this high dose. You have decreased cardiac output, decreased peripheral perfusion. So dopamine really, when you look at the sepsis arena, is a real poor medication, and I think you can research that on your own and realize that dopamine really should be last line. When we talk about giving dopamine, you have pretty major heart rate effects, and you'll see these patients where I've come in on these patients in these smaller facilities where they're maxed out on dopamine at 20 mics per kilogram per minute. Their heart rate's in the 140s or 150s. And so think about the pathophysiology as it relates to that. We're not allowing the heart to refill. Your cardiac output is decreased. You're really counterproductive. You have all this workload on the heart. You have this heart rate that's so high. That's increased oxygen demand, increased oxygen consumption, and you're really defeating the purpose. So really in the sepsis patient or the severely vasogenic shock patient, when you're using a medication like dopamine, really the only indication that I'm going to go to that would be a patient that's maybe bradycardic, where they would benefit from that increased rate. And we'll talk about medications here in a second that are much better. So kind of keep dopamine in the back of your mind. We'll come back to it. But dopamine really, when you get more into critical care medicine, is kind of a last line medication. The next medication we're going to talk about is dobutamine. Dobutamine is an excellent medication as it relates to inotropy, and so that's contractility. We got to remember that there's some side effects to dobutamine. We want to give it in conjunction with something else, and we'll talk about that. So it's a synthetic catecholamine. It's got primarily beta-1 effects, so that's inotropy. It can produce some beta-2 stimulation, resulting in mild vasodilation, and you're going to get that initial vasodilation whenever you give dobutamine initially. So we have to combat that. We got to make sure that the patient's tank is filled. We want to make sure they have enough volume. So always give them a good fluid challenge, 250 to 500 cc's. If you remember from my earlier podcast, no patient, no matter what their etiology or their presentation, whether they're, got congestive heart failure, CHF, whatever, they're all going to benefit from a fluid challenge of 250 to 500 cc's. So remember, always fill the tank. Dosing range is 2 to 20 mics per kilogram a minute, and you're always going to give that with something else. So we'll talk about that. We're going to come back to dobutamine here in a second. But remember, any medication, or I should say any patient that can benefit from contractility, so better squeeze with less heart rate effects, is going to benefit from dobutamine. So for instance, you have a patient that their heart rate is a little high, maybe they're on dopamine, you go into one of these facilities, you realize that they need better squeeze to improve cardiac output, but you don't want that increased rate, right? So dobutamine would be an excellent augmentation medication to piggyback on something like norepinephrine or neosynephrine, and we'll discuss those medications here in a second. All right, so the next medication we're going to talk about is norepinephrine or Levophed. Early on in my career, we always said, Levophed, leave them dead. It was never something that we would utilize. Obviously, most EMS agencies don't carry this, and you would see this in the transfer situation only. But as you start working in the critical care environment, you start flying, you realize that norepinephrine is an excellent medication. And we're seeing it more used now than ever before. And it's the primarily first-line medication for, severe sepsis, septic shock, neurogenic shock, things like that. So, all right, so norepinephrine is our next medication we're going to talk about. Remember the action, it directly stimulates alpha receptors, resulting in constriction of all vessels, and it causes an increase in peripheral vascular resistance. We're going to give this in vasogenic shocks with tachycardia. So this medication does not have tachycardia effects. It's alpha in origin. We're going to give this in sepsis, severe sepsis, neurogenic shock. where you have this massive vasogenic shock. Always going to fill the container. But we're going to give this in doses of 2 to 12 mics a minute, and you can titrate that to effect. Standard to mix this is 4 milligrams of 250 mils of normal saline, and then just again, give it 2 to 12 mics a minute. Excellent medication in the sepsis patient. Should be first line. There may be arguments going first line with neosynephrine, but I think most often you're going to see norepinephrine given first line for sepsis. So back to dobutamine. If you had a patient that you came in and they had this dopamine going at 20 mics per minute, they had this massive heart rate of 140s, 150s, their cardiac output was low, and you needed to switch them to something. It's very important to remember that oxygenation drives everything. If your heart rate is going so fast, it's not allowing to refill, your cardiac output is in the toilet, your body's already in a deficient state, anaerobic metabolism, it's already got tissue hypoxia. We need to optimize cardiac output as quickly as possible, or it's going to lead to end organ failure. So we need to make a switch. We need to switch to something else. And so norepinephrine is an excellent medication. Take the dopamine off, start norepinephrine, start them at a lower dose, see what it's going to do, but augment that with a fluid challenge, fill the container, and start dobutamine. And the reason why you never want to give dobutamine by itself is because you do have that initial vasodilation, and it's because it almost acts as a relaxant agent. So you have initial relaxation of the heart. It causes better squeeze, but it doesn't, that initial drop in heart rate that you're going to see by taking the dopamine off, you need something to augment that. So norepinephrine is going to give you that vasoconstriction. The dobutamine is going to give you that inotropic, that squeeze, and you're going to have a more efficient heart. So you have a decreased rate, better squeeze, better peripheral vascular resistance. So you're going to hopefully increase perfusion, and everything is going to be better. So great augmentation to norepinephrine. The next medication we're going to talk about is going to be neosynephrine. And this is kind of the last medication that we'll hit as it relates to sepsis, neurogenic shock. This medication, I think, people are mostly unfamiliar with it. This is a medication seen in the ICU setting. If you've never flown before, you've probably never heard of this medication, but this is an excellent medication, very safe, used first line, especially in severe septic shock and neurogenic shock. So this has got massive alpha receptor stimulation, causes increased blood pressure without tachycardia. Again, we're leaving the heart rate lower. We're not causing increased oxygen demand. This causes what's called aortic root pressure and coronary artery perfusion pressure, so it increases that. Remember the whole mechanism on balloon pump. Balloon pump therapy is augmentation of diastolic pressure, so we're perfusing the coronary arteries more efficiently during diastole. And we'll do a podcast on balloon pumps here soon, and that'll be a little bit more evident on why we use balloon pumps so often. Indications, again, vasogenic shock, especially in the presence of tachycardia, any severe sepsis, neurogenic shock where you have this massive container failure, and we're going to start these patients at a drip rate of anywhere from 10 to 100 mics per minute. Always start low. Use your cheat sheets, use your field guides, look at the starting dose range, and just work your way up. You got a big window there where you can, once you give them that loading dose, where you can give them a maintenance infusion of 40 to 60 mics a minute. Always watch out for reflex bradycardia. Make sure that you're watching your patients. Again, you can augment the contractility, the inotropy with dobutamine in these patients, and give these patients better squeeze. All right, so that's all I'm going to go over as far as pressure medications. I didn't really want to get into other medications as it relates to vasodilators, hypertensive crises, and things like that. We'll leave that for another podcast. But I just wanted to hit on dobutamine, talk about beta blockade, and how that relates to everything, and then jump into neosynephrine and norepinephrine, and talk to you guys about those things. All right, so that's going to wrap things up for today. If you have any podcast ideas or topic ideas that you want specifically done for FlightBridge Ed, please email me at eric@flightbridgeed.com. Thanks for following us on Twitter, on Facebook, for registering for our review courses around the country. We really appreciate it. If I haven't met you, hopefully I'll meet you soon, and we'll talk to you soon. Thanks.